I'm Katie Bartnett, and I'm here to go over my epidural skills check off with you. This is Mrs. Smith. She's here for labor and delivery. She's 9 months pregnant, and she's getting ready to have the birth of her first child. And she's decided she would like an epidural for pain relief. So I went in and I met Mrs. Smith. I reviewed her allergies with her. She doesn't have any allergies at all. I reviewed her chart and checked her vital signs. Everything looks good there. I also spoke with the nurse to make sure that she got her fluid preload, and she has. She doesn't have any recent shock or infection, no neurological disorders I have to be worried about. And because it's her first kid, she has no previous epidurals for anything in the past. So I'm just going to explain to her the plan. So we're going to place the epidural for the pain control. With anything, we want to explain the risks to her. There's multiple risks. We could have nerve damage, which would be TNS, or permanent direct nerve damage. She could get an infection because we're placing a needle into the skin. That's always a risk. She could have bleeding or a hematoma, pain on insertion. We're going to use lidocaine to numb up that site to hopefully minimize her pain. She could have an incomplete or a failed block. There's a risk of tachycardia. And then also we have the potential of giving her total spinal. With that, she could get nausea, vomiting, hypotension, bradycardia, breathing difficulty, and even potentially death. But one of the biggest risks that we could happen with her would be a post-dural puncture headache. I'm just going to explain it to her because the epidural space is very small. So there's a chance when you're inserting that needle that you may go a little bit too far. And if you do, you could puncture the dura mater, which is the next layer behind that. And that would cause CSF to leak out. So CSF is what is in there to cushion the brain and the spinal cord, and the volume is regulated very precisely. So if that CSF is leaking out, then there's no cushion for the brain and it just kind of sags down. I could just explain to her that that would lead to a bad headache, and if we did go that route, we could try some medications, we could try her laying flat, or we could even try a blood patch. So a blood patch would be that we would take blood sterilely from a vein and we would put it into the epidural space, about 20-30 mils, so that the coagulation factors could stop the leak, and then also that extra pressure is going to help boost up that brain so it's not sagging and hurting anymore. Obviously the benefits is that we can get some early mobilization after her baby comes out, and after we get that catheter out, she'll definitely hopefully be more comfortable while laboring, and then maybe even be able to get a little bit of rest. She's really tired. She's been laboring a long time. She can stay alert and active and be an active participant in her birth of her baby. And then also, if we do an epidural, we can minimize any IV narcotics, so no narcotics getting to the baby. Alternatives is if we've went over everything and she doesn't want an epidural, either we can do no epidural, or we can do some IV opioids, but we can only do those up until she's 8 centimeters dilated. So I would explain all these to her. And our only contraindications that we really have for her is if she refuses, but she already called me in here, so that's not happening. If she's got any infection at the site, I'll take a peek at it. If she has any new tattoos at the site, and then we'll also check her lab and her coag factors and see if everything looks good. So if we have the green light, we're going to get consent from her, and we're going to start the process. So first I'm going to gather up all my supplies, make sure that I have my PPE. I want to have sterile gloves, sterile gowns. We need masks for everybody in the room, even mom, dad, everybody that's there. Have my epidural kit. Now this is going to have the lidocaine and the test dose and the NS for the loss of resistance in it. But if we're going to use ropivacaine or bupivacaine, both were 0.25 to 0.5%, or if we have any narcotics that we'd like to put in there as well. With everything, you want to be prepared in case there's an emergency, so I'd make sure that I'd have a last kit with a lipid emulsion close and a crash cart in case things get wonky. So I'm going to position Mrs. Smith. I'm going to make sure she's sitting on the edge of the bed. Some people like her all the way back here. I kind of like her to be midway here. So Mrs. Smith, I'm going to have you go ahead and push your back out as much as you can and kind of arch it like a cat. and then push your neck down to the bottom. So I'm gonna have her arch this as much as you can and just kind of feel her spinous processes here. I'm gonna look for her 2 fears line, and then I'm gonna come across, and I know that right about here is where L3, L4 is, and that's gonna be our placement. So I would grab a marker if I had one, and I would just mark this site so that we have it. So I'm gonna make sure that everybody has masks on. Everybody has, I have my hat on. I'm gonna go ahead and wash my hands, get myself all clean. And then I'm just gonna open up my kit. Okay, so my kit's all on. I'm gonna go ahead and put my sterile gown on. Super sterilely, you'll be so surprised. Obviously, real life, I'd be making sure that I'm putting this on as sterilely as possible. And I would have an assistant come and help tie me up so I'm not all over the place. Okay, and then I'm also putting my gloves on super, super sterilely. Okay, so now that we're all sterile and good to go, I'm gonna use this and I'm gonna pour it out here. Pour it out here, throw it in my trash, and then I'm gonna start cleaning the site for the patient. So again, this is where we're gonna go for our patient. So we're just gonna start cleaning, and we'll go out in a nice big line. Okay, that looks good. Now we're gonna get the rest of our kit all ready here. So, I'm gonna use this to kind of place under her bone and have a little bit of an area for us. All right, Miss Smith, scoot your bottom up just a little bit here. I'm gonna get this positioned underneath you. She didn't scoot very well. I'm gonna go ahead and drape the patient. I would normally unstick this and put it on the patient, but our patient has a very wonky, weird back. So, as sterilely as we can. I'm gonna say to him, sterilely. All right, we look good to go. So now I'm just gonna get my kit all ready here. So first, I'm gonna pull up my lidocaine. So we're using 1% lidocaine. I would crack this open and then pull up my dose here. And this is just mainly gonna be to numb the site. Okay, got that already. Next, I'm gonna go ahead and get my loss of resistance syringe ready. You want to be really careful with this because once we get the saline in here, sometimes this can slip out and it's glass. So some people use saline, some people just use saline with an air bubble, some people use just air. So it all depends on what your preference is, but for the sake of this, I'm going to say that I'm pulling up saline into it. And if I want to, I would use this straw that's got a filter on it, but for the sake of this, we're just gonna say that that's good to go. And then I can also get my test dose ready now. Use the straw for this. Okay. All right, so now we have it all ready here. I'm gonna grab my lidocaine. Okay, so with my lidocaine, I'm gonna use about 3 to 5 mils. This is just a 3 mil syringe, so that's how much we're gonna use. And we're just gonna come in here and kind of go right around the site, squirting a little bit as we go, just so that we can get it all numb. And then some people can even go a little bit deeper and let some out while they come out. Okay, that looks great. I'm going to give that a couple minutes to set in so that it can actually be numb. So while she's doing this, I'll just keep coaching her through what we're doing, let her have a couple contractions, and then educate her that we're getting ready to go. So I'm going to bring this a little bit closer. So I'm going to grab my 2E needle. This is a 17 gauge. I'm going to take the cap off here. And then we're going to want to make sure that this is bevel up. So as we're going in, we're going to insert at a level angle. And we're going to insert just until we start getting into those ligaments. Okay, so I'm starting to meet a little resistance here. So I'm going to take this out. And I'm going to carefully grab my loss of resistance syringe. I'm going to put this on. And then I'm going to make sure to hold this needle super tight. And then I'm going to see if I can get in. And I can't. So then holding it, I'm going to advance it a little bit more. See if I can get in. Nope, so I'm going to keep going. Oh, and I felt a pop there. And then we're just sliding right in. So that shows us that we're right in the right spot here. So I'm going to note my depth. It looks like I'm at about 5 centimeters in. So when I'm inserting my catheter, I want to make sure, sorry, this is going to go. There we go. And I'm inserting my catheter. I'm going to note the depth on here, and I'm going to make sure that I go at least 5 past that. So we'll go 10. Some people will go a little bit more if they're obese. Since she's a lovely mannequin, she only goes so far. So now that we're in, in that I would also let the patient know that they may feel a little bit of a zing. I'm going to be coaching them through all of this. So now that we're at the right spot, I'm going to go ahead and remove this needle. Hold on to this catheter. Okay, now I'm going to place the Lurolap on this catheter. So this is just going to go right in, and we're going to walk it down. Okay, so now that it's locked in here, we want to get some baseline vital signs for the patient, just to make sure that they're at the right spot. So now we are going to take our testo syringe here. So first when I connect, where's my filter? There it is. I'm going to connect the filter to it. Okay. So now before I go ahead and pull it in, I'm going to pull back, make sure that I'm not getting any blood return or any veracity change in here. We don't have any CSF or blood coming into here. So everything looks good. So I'm going to educate Mrs. Smith while we're doing this. The point of the test dose is to make sure that we aren't in the subarachnoid space and that we aren't in any of the epidural veins. So we're going to be slowly introducing it, very slowly. So we're going to be using 3 mils, and it's the 1.5% lidocaine with 1 to 200,000 epi. And what that's going to give us total is going to be 50 micrograms of epi and 45 milligrams of lido. The epi is going to tell us within 30 seconds to a minute, they would start noticing a 20% rise in heart rate or blood pressure if we're in those epidural veins. And then if we're in that subarachnoid space, that lido is going to cause a significant block within 3 minutes. So we're just going to keep slowly pushing this in. Just talk, you're doing great, Miss Smith. We're almost done here. You should start getting relief here soon. So we'll monitor the patients for 5 full minutes. We're going to cycle our vital signs after this test dose for 15 minutes so that we can make sure that we're checking on that. Okay. bad soon. I'm gonna go ahead and cap this off. So I'm gonna record how many centimeters my catheter is out. Like I said, we placed it about 5 centimeters past how far we were in. We're gonna secure it with a holder. Some people like to use this tape that comes with it. We can also use a tegaderm or anything like that. We just wanna make sure that the site is visible so that we're not seeing any kind of a hematoma or that it hasn't slipped or anything like that. So you can kind of wrap it around here, and then you're gonna come up the shoulder and get it all secured for the patient. And then I'm gonna make sure to use the label that's in here. We're gonna put this on the catheter and on any tubing that we would use so that nothing gets infused in here that shouldn't be. So now that I have it in all secure and good to go, I'm gonna do a bolus dose of 8 mils of 0.25 bupivacaine over 10 minutes with 2 mils of fentanyl in it. And then if we wanted to do a continuous dose for her, we would do the bupivacaine at 0.125%. And we'd make sure to check our dermatomes, make sure that she's feeling it equally on both sides, and just keep checking back with her and see how she's feeling and chart the procedure. And that'll be it. Thank you.